Hi, my name is Dr. Matthew Reddick. I'm a genitourinary medical oncologist at UCLA School of Medicine, and I'll be moderating today's virtual tumor board. I'd like to introduce you to our panelists. First, we have our medical oncologist, Dr. Susan Slovin. Dr. Slovin, please tell us about yourself.
Thank you, Dr. Reddick. I work at Memorial Sloan Kettering Cancer Center in New York. I'm also a genitourinary medical oncologist whose focus has been on prostate cancer with a longstanding interest in prostate cancer immunotherapy and biologics. Thank you for having me.
Hello, I'm Dr. Pritesh Patel, Associate Professor of Radiation Oncology at Emory University, focusing on GU malignancies.
My name is Jason Abel. I'm a surgeon, the chief of urologic oncology at the University of Wisconsin.
I'm Dr. Tyler Fromm. I'm a radiologist at Washington University School of Medicine in St. Louis. I'm an assistant professor with appointments in both abdominal imaging and nuclear medicine. So I do a lot of oncologic imaging below the diaphragm.
So this is a case of a 75-year-old Caucasian male presented with an elevated PSA and an abnormal digital rectal exam with a palpable right-sided nodule, and was diagnosed with high-risk prostate cancer, T2A, N0, M0, Gleason 4+5 with a PSA of 6.2. And ultimately, the question will be, what is the best treatment for this patient? So the patient originally presented with daytime frequency, nocturia, and occasional weak stream. His performance status is excellent with an ECOG of 0. His medical history is notable for coronary artery disease, cystic adventitial disease, hypertension, dyslipidemia, left and right popliteal artery occlusion, bilateral hip replacement, history of blood clots, and osteoporosis. So a lot of cardiovascular disease. Social history is notable for no tobacco or drug use and uses alcohol weekly. The family history is notable for his mother with a history of lymphoma. The oncological history is such that in February of 2021, the patient was noted to have an elevated PSA at 6.2 with the abnormal digital rectal exam. A prostate biopsy was performed, which showed Gleason 4+5 in 3 of 12 cores. At the right apex, there were 2 of 2 cores involved, and at the right mid-gland, 1 of 2 cores involved. In March of 21, the bone scan shows no metastasis, but L3, L4 degenerative joint disease, and a CAT scan of the abdomen pelvis is negative, but there's limited evaluation due to artifact from the bilateral metal hip prostheses. In May of 21, an MRI of the pelvis shows extracapsular extension that abuts the right neurovascular bundle. So I'll ask Dr. Fromm to review the MRI with us.
Yeah, so I'm not sure these images really capture the finding particularly well, but here we have sagittal high-resolution T2 weighted images through the prostate, and we're told that the patient had extra-prostatic extension. I don't believe that I can really point that out specifically on this image, though I think that we're certainly looking for kind of a regularity of the sort of normally T2 hypointense margin of the prostate, asymmetry of the neurovascular bundles, or any evidence of tissue, enhancing tissue in the fat adjacent to the prostate. We have other things that we can look for in terms of the presence or absence of a bulge at the site of the tumor, and the curvilinear contact length to generate something called an EPE, or extra-prostatic extension score, that based on the number correlates with the probability of having extra-prostatic spread. I will say in this case that I think the beginning of the case mentioned this was a T2A tumor. If we believe clinically, like based on this MR, that there is extra-prostatic extension, I believe that would be a T3A instead. So just a little point of clarification there, perhaps.
And can you comment generally about the utility of MRI in terms of the initial staging of prostate cancer?
Yeah, so it's in a patient who has biopsy proven prostate cancer. That's one of the sort of most common indications that we have for doing a prostate MR. And sometimes it's a patient who has relatively low risk prostate cancer, like a Gleason 3+3, is considering sort of expected management or close surveillance, and we're just sort of looking for a site of more aggressive disease that might warrant dedicated sampling, or in a patient who's perhaps going to go on to treatment, looking for any evidence of extra-prostatic extension that would potentially alter the approach of the surgeon. So do we see rectal cancer invasion? Would perhaps a urologic surgeon want to have someone from colorectal surgery involved in the case at the get-go? So things like that can kind of alter the initial management strategy. Certainly for radiation planning, it's very helpful to have that sort of delineation of initial disease. This would also be a patient in whom, with the recent approval of the F18 PSMA PET tracer, I think would qualify for initial staging per the FDA label, assuming that they're potentially a candidate for initial definitive therapy, because this would be a high-risk prostate cancer. So it would be a patient in whom I would really think it'd be beneficial to try to get that PSMA PET CT, the pelvic MR, or perhaps even initial staging PSMA PET MRI, if such technology is available at a given center.
Thanks, Dr. Frum. You actually answered the question that I was going to ask about PSMA-based imaging. So in a case like this with high-risk prostate cancer, PSMA PET CT scan is very useful. We see stage migration in about 30% of patients. The patient will see extra-prostatic involvement, lymph nodes, or even distant metastatic disease in patients who have high-risk prostate cancer. Yeah, thank you for that. And I think the patient's imaging, including a bone scan and CAT scan, are appropriate. So we now have a patient with high-risk, high-grade prostate cancer with potentially extracapsular extension on MRI. So there are a number of treatment options. And I'm going to ask Dr. Patel from Radiation Oncology to comment on the role of radiation therapy for this particular patient.
Yeah, I think that this patient seems to be an excellent candidate for a curative intent radiation therapy plan. So as is our usual standard, typically a combination approach with androgen deprivation therapy and then dose escalated radiation. So in our practice, we do try to use a brachytherapy boost whenever feasible to optimize the outcomes in particularly in high risk cases, particularly Gleason 9 and 10 disease. So careful evaluation of the MRI really is critical. If the disease is too far lateralized, extending along a neurovascular bundle, or in some cases the seminal vesicle, that can render it ineligible for brachytherapy. But medial seminal vesicle or medial neurovascular bundle invasion, typically we can still cover, particularly with HDR brachytherapy or a catheter-based brachytherapy. So in this case, I would aim for a brachytherapy boost followed by external beam radiation to the prostate, the seminal vesicle, and the pelvic lymph nodes prophylactically, really to optimize our outcomes. I would ask Dr. Slovin really about the androgen deprivation, particularly maybe an oral agent, given some of the medical history here.
I just wanted to reiterate something that you alluded to about the Gleason grade group 5, the Gleasons 9 and 10, with a very good retrospective data showing that such patients really benefit in terms of clinical outcome, including survival, with a combination of external beam radiation and brachytherapy, which seems to be superior to either one of those modalities alone or surgery. So thank you for that. So yeah, Dr. Slovin, we'll turn to you about the role of androgen deprivation therapy, keeping in mind that this patient has a pretty severe cardiovascular disease and has peripheral vascular disease.
Thank you very much. Once again, a very challenging case. First order of the day would be genomic profiling. We have a high-risk patient. And even though there's no significant family history, nevertheless, it's high risk enough for us to worry about BRCA mutations or anything that might be actionable for consideration of PARP inhibitors in the future, or something that would obviously be important for his sons if in fact he has several. In general, our treatment approach would be based on the Latitude and Stampede trials. We would be doing androgen deprivation therapy along with abiraterone and prednisone for a treatment time of anywhere from 18 to 24 months. One of the concerns I have very often in patients when they go on androgen deprivation therapy, particularly in the setting of high-risk disease, if patients are allowed to continue for roughly 24 months, there's always the possibility of becoming castration resistant sooner than would be otherwise expected. Similarly, in some of the older men, and this is not old by any stretch of the imagination in this case, but I would say probably 10, 15% of men may never have an opportunity to recoup their testosterone back to non-castrate levels following the duration of the treatment. Now, Dr. Reddick brought up a very important point, and that is cardiovascular risk. We are dealing with a man who's a vascular path. There's no question. He has all sorts of things that are going to be problematic. And therefore, open communication with his cardiologist or primary care physician is actually tantamount to really having what we call comprehensive care. Recent data suggests that an oral GnRH antagonist, relugolix, had improvement in terms of potential reduction in cardiovascular risk factors. We do know that there have been multiple attempts to discern whether or not there's a difference between using a GnRH agonist, such as leuprolide, versus that of an antagonist, such as degarelix. And the recent New England Journal of Medicine paper, which did not really show adjudicated MACE events, nevertheless suggested that there may be an important role for an antagonist, particularly in terms of reduction of cardiovascular events. So the long and short is that somebody like this needs to have really very close monitoring with the primary care physician or outside cardiologist. He is at high risk for cardiovascular events, hypercholesterolemia, hypertriglyceridemia, and the like. And therefore, one really needs to make this into sort of a multidisciplinary evaluation and follow-up at all levels. It's not just for the medical doctors, it's for the radiation doctor and the urologist who's involved as well.
Thank you. Dr. Abel, we've talked about radiation with hormone therapy. Do you think there's any role for a radical prostatectomy in this 75-year-old patient with cardiovascular disease?
Yeah, so I think we would probably discuss it, but I think for all prostate cancer patients considering surgery, we would discuss the effects of each treatment on urinary function, sexual function, and cancer control. I think this patient's comorbidities probably put them in a higher risk for surgery. I mean, I think that definitely, I think probably is a little understated, but we would discuss it with them. I think a lot of people would not think this patient would be ideal for surgery, but I suppose if you're going to make a case for a tangible benefit of surgery in a patient like this, is you have the ability to understand the tumor biology a little bit better by examining the entire prostate specimen, which does reduce some of the uncertainty in these patients as they move along. Because he is a patient that theoretically could be cured, but it's very unlikely because of this very aggressive disease, as the panel has pointed out.
Thank you. And I would just ask the panel, given that the patient is apt to be recommended for a combination of external beam radiation and brachytherapy, how would that influence your recommendation vis-a-vis the duration of androgen deprivation therapy, as opposed to a situation where a patient was getting external beam radiation therapy only? Anyone have any comments?
I can comment. There's a recent study that had tried to address this question, although it wasn't the primary study endpoint. But the TROG radar study was a study that actually compared long and short course ADT in high risk prostate cancer patients. But there was the option of multiple different radiation schedules. So a standard long course external beam was one of the options, and then 46 gray with brachytherapy was another option. So that was a stratification variable, not randomization. That being said, the benefit of 18 months of ADT over 6 months was preserved even in the brachytherapy group. In fact, the effect size was maybe even larger there. So in general, I view them now as really independent, optimizing the radiation technology and then optimizing hormone therapy. I view them as pretty independent, largely based on the report of that study.
Thank you. If there are no other comments, I'll summarize.
Oh, Dr. Reddick, I'll add one more thing.
Sure.
This patient is likely to be a candidate for an ongoing national trial, NRG GU009, which is using a genomic classifier to intensify and de-intensify therapy in high-risk prostate cancer patients. So that study is currently on hold, but when available, we at our institution, we would likely offer enrollment on that study.
Thank you. So in summary, we have a 75-year-old male with newly diagnosed high-risk prostate cancer. Patient has a significant history of cardiovascular disease. In balance, we are first recommending that the patient undergo germline sequencing to try to detect a hereditary cancer syndrome. And two, for the patient to undergo a PSMA PET CT scan if feasible. In terms of treatment in balance, we're recommending a combination of radiation therapy to include both external beam radiation therapy as well as brachytherapy, plus hormonal therapy. And that hormone therapy can be enhanced androgen deprivation therapy, with androgen deprivation therapy plus abiraterone and prednisone per the STAMPEDE study. The androgen deprivation therapy can certainly include an LHRH antagonist, which may be associated with fewer major cardiovascular complications. So something like degarelix or relugolix would be a reasonable approach.